In the current literature, LVADs are now referred to as mechanical circulatory support. So I'll present to you the Utrecht experience with regard to advanced heart failure. This is my disclosure. I build up the presentation as such. Since the inception of mechanical circulatory support, it was closely related to heart transplant, the golden standard of patients for heart failure. So I'll discuss the results of the heart transplantation and its merit and its limitations. Then I'll discuss the merits and limitations of MCS therapy and end up with my conclusions. My presentation contains a lot of survival slides, and this is the first one from the International Society of Heart and Lung Transplant, presenting the results of heart transplant. On the x-axis is the survival, and on the y-axis is the time in years. Note the 1 year survival of 80%, the 3 year survival of about 65, 3 year survival of 75, and a 5 year survival of 70%, and a 15 year survival of 50%. In these slides it's about varying between 40 and 50. Remember the 5 years results of 70%. However, there is a severe donor shortage in our country, as illustrated in this slide from the Dutch Transplantation Society. On the background of this slide, you can see the ever-growing patients needing a heart transplant in gray. The blue part shows the number of transplants performed. It's obvious that the number of heart transplants will never meet the need for patients with advanced heart failure. So in 1993, we started an MCS program as a bridge to heart transplant to offer these patients an opportunity on the waiting list. This was with the pulsatile devices, the HeartMate 1, and we successfully bridged 80% of the patients to heart transplant after a mean duration of half a year. The publication of the Rematch trial in the New England Journal of Medicine in 2001 supported this form of therapy. A trial where patients non-eligible for heart transplant were randomized in an optical medical management arm and an MCS arm. This trial was conducted with the HeartMate 3 as well. This is also survival slides. It was early terminated because of the superior results of the MCS therapy group after 1 year with a survival of 50%. Mind you, this is not even close to the heart transplant, but still good in comparison to the medical therapy group. This slide also learns the following. There are 3 phases in this slide. The beginning, dictated by patient selection. The middle part, the slope, is dictated by the complication of the large bulky devices, which was the HeartMate 1. And the last part, where the durability of the device is very poor. And with regard to the latter two, the devices were developed, were miniaturized, and void of biological valves with increased durability. And the devices mentioned here is HeartMate 2 and HeartMate and the hardware. With regard to the patient profiles, these patient categories were identified in the by Intermax. I'll just shortly mention them. Intermax 1 is the critical cardiogenic shock patient, the crash and burn patient that we've discussed the first few talks. 2 is progressive decline patients who are sliding on inotropes. Class 3 patients are stable but inotrope dependent, so they are stable on inotropes. Intermax 4 patients are frequent flyers. They have symptoms and rest, and they are frequently back to the hospital to optimize them on medical therapy and send them back homes. And so on, they continue to go to Intermax 7, who are much more stable in their complaints. And the higher the profile, class, the better the survival. So what has this improvement of therapy um, delivered us and the better devices? This is the Intermax report published in 2015 with survival after MCS in the United States. With the LVAD, you can see a 3-year survival of 60%. And, and, uh, and mind the BIVAD support, which is very poor, and that you'll never be the same as heart transplant. So a better survival, but still not there yet. The same for the European results. This is the first annual Euromax report. Collega De B will discuss this on Tuesday as well. And here we can see a 3-year results of 61% and also a poor results of the BIVADs, which is in green underneath. And between March and 2006 and January 2016, we had 189 patients implanted in our center, and we evaluated these results presented at the ISHL meeting of April last year. And to my surprise, we saw a 3-year survival of 75% and a 5-year survival of 68%. The endpoint was death, transplantation, or recovery. And this equals that of heart transplant. Except for survival, however, quality of life is also improved. Patients can resume their daily activities. However, this therapy is not without risks. In this event-free survival slide, where you can see on the x-axis the patient freedom of events and on the y-axis time, you can see that within 1 year, about 70% of the patients has one kind of major event. And the major events are infection, bleeding, device malfunction, stroke, or death. Here I'll just summarize the complications again. GI bleeding, patients on the long term with repetitive colonoscopies for unknown anemia and melena. Neurological complications, hemorrhagic and ischemic. Once a neurological complication, the survival after with this therapy is much poorer. Infections, which are nowadays manageable by conservative management. Mechanical failure, driveline problems, and pump thrombosis, which necessitates replacements of the pump. Long-term RV failure with high mortality, and the patient has to adjust their lifestyle because living with batteries has some responsibilities. This slide is to quantify the complications presented in events per patient years. This is our results, and I'll point out a few, which are not all of them in red. The GI bleeding, for instance, you can see them at 0.15 events patient years. The neurological complications underneath in red with disregarded TIAs. Ischemic and hemorrhagic CVA is 0.15 events per patient years, which is a high number, and it's a very devastating complication for these patients. Infections, 4 categories. These are Intermax definitions of complications. The localized infections are all infections which are, for instance, urinary tract infections, pneumonia, so that's what every patient in the community gets. It's high. The exit site infections are 0.10 events per patient years. The other more serious infections, they are as mentioned there. Late RV failure is also a big problem. 0.20 events per patient years, where there is no adequate solution in Holland. Well, we can put in an LVAD, but as a bridge to what? Seeing the lack of heart transplants, we cannot offer these patients a lot of solutions. Last thing, we replaced 20 troop pumps in these 189 patients during the period mentioned. The limitations of MCS therapy is by its complications. patients need lifestyle adjustments, and it's important to point out that MCS therapy is univentricular support, and heart transplantation is biventricular replacement. I would like to conclude: therapy for end-stage heart failure. Heart transplant is still the golden standard for advanced heart failure. However, mechanical circulatory support therapy in a highly selected patient group can be a separate therapeutic modality. And for a successful program, you need a multidisciplinary team, a 24/7 assistance team, and an experienced center. Thank you for your attention.